So welcome to this lunch break symposium, Impacting AMI Outcomes, New Paradigms and Learnings. This is a non-CME sponsored session from Miracor Medical. Just in terms of a few quick introductory remarks, I had the privilege of being involved in the very early days of primary angioplasty, and that's actually when an era, if you can imagine what our country looked like when thrombolytic therapy was the principal way that we treated patients with acute myocardial infarction. And I was one of the co-PIs of the early PAMI trial, and working with Bill O'Neill and Cindy Grinds and Bruce Brody and others, we and others had a major impact on the way STEMI was treated. And we made some real steady progress in learning how to optimize outcomes with primary PCI for a good 10 or 15 years, looking at the importance of door-to-balloon time, et cetera. But then I think our outcomes really kind of peaked. And we really didn't go much beyond that. And for the last, I would say, probably 20 years, we really have not had a lot of major change in the outcomes of patients with ST segment elevation MI. And there's a variety of reasons for that. But basically, we need newer therapies and new approaches to two major problems. One is cardiogenic shock and the high mortality after that. And the second is patients who have large infarcts. And that's what we're going to be talking about today, principally non-shock patients with large MIs. And we're going to talk specifically about a new emerging therapy for such patients called PICSO, or pressure-controlled intermittent coronary sinus occlusion. So I see here my partner Tim Henry has made it. So with those opening remarks, I'm going to tell Tim to leave his tea alone and stand back up. And let's see, now we've got to go back to yours. I thought I was going to have to go. Let's see.
Right there.
Yeah, let's see. Okay. So we're really pleased to have Tim Henry here, who is going to give us the overview talk, the first overview talk on STEMI progress, peaks and plateaus from the ICU to the present. All right. We'll see. I clicked start.
Start.
Let's see. There
Good.
we go.
All right. Thanks, Greg. And so what my goal is really, I'm going to talk about STEMI care. Does it do it here or here? Right there? I'll do over here. Okay. All right. All right. So I'm going to talk about STEMI care. What do we know and what do we need to know and where our challenges are? And so briefly, this is the problem, right? So you have plaque rupture, and the solution is 1 hour artery cleaners. That I still love that slide after all these years. So think about how far we've come. Do you know in 1988 the ICU trial was published where we thought it was ethical to put someone on nothing? So patients were randomized nothing, aspirin alone, streptokinase alone, or a combination. So really, in that time, we've progressed. We know that PCI is better than lytic at every time point, and we know that's true even if you transfer patients. So that's what we have. I love this slide. Humanity's greatest advances are not in its discoveries, but how those discoveries are applied. So we had a lot of data, but you have to put it in place. And then I think the development of regional STEMI systems led to really significant progress. But then I think we have plateaued, and we'll talk about what those challenges. So what is clinical practice? PCI centers should do PCI in a timely manner, less than 90 minutes. Really, that should be less than 60 minutes for almost all patients from first medical contact to PCI. Short distance transfers should have PCI in a timely manner, less than 120 minutes. I think long distance transfers or people with expected delay remain a little controversy we'll touch on. How far have we come? This is data in the United States, so the number of STEMIs is actually going down. Mortality has gone down, and the number of people getting PCI has gone up, and it's over 85% now, so we have made. Well, I want to point out this is a worldwide problem. So it's better in the United States, but it's not in most of the world. So if you look at Malaysia, Indonesia, China, India, the number of patients having STEMI has increased, and it's occurring at a younger age. So this is still a big worldwide problem. What have we learned? We know you can do it fast. We know it saves lives. You can expand the benefits of PCI by having regional STEMI systems. You can do it accurately. You can decrease eligible untreated. You can improve outcomes, cardiogenic shock, elderly, and a lot more. So let's give you an example. Look in the right. If you don't have cardiogenic shock or cardiac arrest, this was a time when there was 2,000, only 4 out of 2,009 patients died. That number now in a big registry we have called the Midwest STEMI Consortium, I have 8,000 people in that group. There's only 5 people who died in the hospital out of 8,000. So if you come to the hospital and you're under 70, no cardiogenic shock and no cardiac arrest, you should do fine. If you look at outcomes beyond mortality, the need for an ICD at 1 year, less than 3%, recurrent infarction, less than 3%, recurrent admission, less than 8%, and half of that is elective. Heart failure is also gone. So we've come a long ways if you're in a system that's doing this well. Key components have standardized components, have individualized transfer arrangements to get to the PCI center, single phone calls, you empower the emergency room, even better, the paramedics, and lots of training and really feedback and quality assurance. Even better, after you do your STEMI network, you should do all acute cardiovascular emergencies and standardize them. So that's really, this should be the state of the art. But what are the challenges? So I'm going to talk briefly about the challenges. Multivessel disease, 40 to 65% of people have it. They have worse outcomes. The complete trial really showed us that these patients should have complete revascularization. And that is, when you do that, the timing is a little unclear. It can be out to several weeks after discharge. It can be at the same setting, it can be the same hospitalization. But if you do complete revascularization, you have a significant reduction in death or MI, and the secondary endpoint, which included ischemic-driven revascularization. So I think that is solved for non-cardiogenic shock. What about in-hospital STEMI? You know where the worst places to have a STEMI is? In the hospital. And most hospitals don't have standardized protocols in place. This is our data we published in Circulation a few years ago, that if you were in-house, you had higher mortality in hospital 30 days than at 1 year. When we put in a standardized protocol, we were able to cut the mortality in half. So if you don't have an in-hospital STEMI program, you should have protocol, you should. What about expected delay? So patients too far aren't going to meet 20. This continues to be a problem, but not only in the United States, but throughout the world. And I will tell you the approach to that, really we know now is a pharmacoinvasive approach. Dialytics, a half dose or full dose. Go to a hospital that has PCI and do PCI within 3 to 24 hours. Out-of-hospital cardiac arrest is another big challenge. If you do a program with your STEMI program, you can get to the point where you actually have survival hospital discharge neurologic intact for 66%. So really, we've made progress with that. Advanced cardiogenic shock is another one I'll touch on. We know now the value of the SCI shock classification is very helpful to show you who are the highest risk patients, and that's in particular the D and E patients. And another really important issue is the combination of cardiac arrest and cardiogenic shock is in particular high. So these remain our challenges. And a really important part of that is we should be developing shock networks so that patients go to one place that have standardized protocol and a shock team, and it deals with the best way. So the next issue is really a really important one, and we'll deal with that a lot today, and that's microvascular obstruction. So on this list, these are all the STEMI people who are doing poorly. And microvascular obstruction is a really big one. So this is the microvasculature. It's far more important than epicardial disease if you think about the extent of it. And what we know is both STEMI and non-STEMI, that microvascular obstruction correlates with increasing heart failure and increasing long-term bad outcomes. And this is an example of that. So no microvascular obstruction, you do almost have no events. With microvascular obstruction is where almost all the deaths occur. And you're going to hear a lot about IMR tonight, but really IMR correlates very well to the presence of microvascular obstruction. So really, personally, I advocate for when you have a STEMI, especially large anteriors, we should be doing IMR because we could be finding out the high-risk patients at the time. And it also correlates IMR with infarct size and with recovery. So we'll hear more of that. And the last thing I'll end with a minute in terms of a challenge for STEMI, and that has been COVID. So this is what COVID looks like, and it's both been the direct effects, so that COVID patients who have ST elevation have very thrombotic lesions. They're more likely to have MINOCA or no obstructive coronary lesion. And on the other side, the indirect problems with COVID are this. Well, this is actually COVID STEMI. So this is from the NACME registry, and we have 900 patients with ST elevation and COVID, and you can see the mortality in the hospital is 30%. So markedly higher than other patients. But this is the indirect effects. We showed early on that there was a 40% reduction of patients actually going to the hospital. And what did that do? This is not COVID patients now, this is STEMI data. You can see patients were much more likely to present late. They had lower ejection fractions, and they had increased mortality. So we went backwards about 20 years during COVID. There was also an increase in late complications, and there was an increase in out-of-hospital cardiac arrest. And what patients, when you asked them, the number one reason why they didn't want to come to the hospital was they said they were going to get sick. So with that, oh Lord, here comes circumstances beyond our control. I don't believe that. I think we can fix it. Like Yogi said, you got to be very careful. You don't know where you're going because you might not get there. So now we're going to find out how to deal with those challenges.